Thank you very much. It's very nice to be here. I'm hoping to give a little bit of a description today about what is going on up north of the border. I don't know whether that's in preparation for any shenanigans that are likely to happen in the very near future, but you never know. So we might have to plug into your ecosystem a little bit quicker than we've been planning to so far. What we're doing in the north at the minute is we're trying to build an information ecosystem to pull together information and data that's coming from multiple different sources. My presentation is not largely focused towards the patient side of things at the moment, but I hope you'll be able to see that there are areas in here where we are trying to specifically engineer this in such a way that we can then bring our patients on in, and I'll welcome any sort of comment that might go on with that. But like many health ecosystems, pretty much everywhere, we're dealing with a fragmented ecosystem that's been developed over the years by funding that's been coming from multiple different sources. It's not strategically directed towards doing things, and in fact our health system is based on 5 acute hospital trusts that have 9 patient administration systems that are still running as separate instances at the same time, and that presents a data interoperability nightmare, as you might imagine, even within the one hospital trust. And then lots and lots and lots, hundreds of little isolated systems. These would include patient-facing systems, such as our quite successful but nonetheless very low-tech renal patient eMed system, which allows our renal patients to get access to all their data, or much of their data. And it's very healthcare professional centered. It's all about the doctors. In fact, it's not even about the nurses even very much. It's nearly all about the doctors. And this needs to change, and this needs to be set up in a proper way. And of course, 99% of it nearly runs on paper. And paper is still a very core part of all that happens with it, and that's why a lot of things go wrong. So what we have had over the last 6 years or so is an electronic care record, which has been a very successful IT implementation thing. It's one of those rare beasts that's a successful healthcare-based IT rollout that joins all our appointments, letters, our lab results, our x-ray results, and lots of stuff together across all the trusts. But it's great if you're in the hospital. If you're a patient, not so great. So we're working on a process at the moment for our dementia patients and their carers to roll out a portal into that data to give them access to this. And it's been a fantastic success so far. So where we're moving that towards now is a new thing called Encompass, which is an electronic health record that will do away with all those different patient administration systems and map out the healthcare process as one single unit. Those of you who have done work with electronic health records will have heard the name of the company Epic, and they're the ones we're going with, and that presents a lot of challenges because that's a big American corporation, and big American corporations, in fact any corporation, you're dealing with closed data systems, and how do we get that information out and make sure that that then is something that we can choose to deploy out to other clinicians and to our patients and to other areas of the healthcare system. This mess is what I want our healthcare ecosystem to look like, to bring all the different groups together, but to kind of collect everyone together in this spider web of informatics, that the data is flowing around so that it can actually start to do what we needed to do. So how does that then apply to my day job of genomics and genetics? Well, genetics and genomics obviously has the rare disease aspect to it, and our patients obviously, like, as you know, and many of you in this room will know, it's like crawling through a desert looking for that oasis that's going to tell you or give you a diagnosis. But then even what happens the other side of your diagnosis? Where's the benefit out of that? We want to bring information that we're getting from the UK 100,000 Genomes Project, so whole genome sequencing data, to actually be of benefit to patients. But there's one key thing that people don't get. You need very clear, detailed phenotyping. And I know that's been mentioned a few times before and was mentioned before I even arrived here, so I'm sorry I missed the talks on that. But you need to know what's actually the matter with your patient before you can say what you think the cause of the thing is, because interpreting genomes is no easy thing. So what we're trying to do is build this system that at the bottom here, I've called it GenOceanic, the Genomics Open Core Engine for Accelerating Northern Ireland Care. It's called that because back in the olden days, you'll remember a company called Harland and Wolff who used to build ocean liners. And the largest ocean liner in 1899 was the Oceanic. And it didn't sink, at least not then. I thought this would be a good thing to call it, and I couldn't come up with a good acronym that would have Titanic on it, and I thought it would have too many other annotations. The purpose of this is to be a regional system across the 2 million people who live in Northern Ireland, and then also to tie into other health ecosystems elsewhere. And obviously, I'm here today, you guys are here today, I'm looking south of the border as well to make sure that we can keep that all going, even whatever Boris decides he's going to do with the stuff. It's based on open standards, and I know Deepak has been talking about that before. We need to know on our side what we're talking about and what is going on in your side. So we want to pull that together, like I'm trying to suck data in from any different source and present that in a way that it makes it meaningful, useful, and certainly beneficial to our patient population. Thank you very much.